Welcome to this afternoon's webinar. We're going to go over some case studies in myofascial pain and fibromyalgia. This is Dr. Bernard Filner from Rockville, Maryland. At the end of the session, if you have any specific cases or questions or concerns about these cases, please put the questions in the chat box, and or specify a case in there, and we can discuss it. Now we'll proceed. This is the first case of patient of a young woman who is in her late 30s, who presents with a low back pain and a diagnosis of carpal tunnel on the right wrist that is documented on an EMG that shows slowing at the right wrist, and a diabetic neuropathy involving both feet. When she is seen, she is complaining of low back pain, wrist pain with a loss of grip strength, tingling on the tips of fingers 2 through 4, but no thumb pain. She has no symptoms whatsoever on her thumb, all on the right side. As you may have heard, some of the thinking outside the box, even though this patient comes with an apparent EMG diagnosis, a confirmed diagnosis of carpal tunnel, without any symptoms whatsoever in the thumb, it begins to make you wonder whether this is in fact a carpal tunnel. She also has a loss of sensation from ankles to the tips of her toes for approximately 3 years. She states that her blood sugars have never been above 180 milligrams per deciliter, and that she has insulin-resistant diabetes. Now, the first thing that was evaluated was her low back pain. The neurologic examination demonstrated a negative straight leg raising test, minimally to absent ankle reflexes, normal deep-tended reflexes at the knee, and normal reflexes in the upper extremities. The neurologic examination in the upper extremity on the right demonstrated no sensory deficit on the thumb, and the pinwheel elicited some tingling on the tips of the 4 fingers, but there was no other sensory deficit on the hand. The straight leg raising test was negative. In my particular approach to these patients, a negative straight leg raising test basically rules out a disc. It would be a rare occurrence for there to be a disc if the straight leg raising test were positive, and a positive straight leg raising test means pain below the knee, not in the buttock or due to tight thigh muscles. Now, on exam, she had exquisitely tender trigger points in the quadratus lumborum muscle, which is here, and the iliocostalis muscles. She also had numerous trigger points in the piriformis, the gluteus, the vastus medialis, and lateralis. When the quadratus lumborum muscle and the iliocostalis muscle were done, all the other trigger points that I mentioned up here simply disappeared without any kind of treatment. This is a classic presentation of using these core trigger points to resolve symptoms in the extremities. You don't see it very often, but often you have to treat some of these trigger points, but in this case, no treatment was necessary. Patient said her leg felt light, and that the only symptom remaining was that her both feet were numb. She still had the gastrocnemius medialis and the peroneus longus trigger points in both lower legs. Inactivating these resulted in a completely normal sensory examination of each foot. The entire symptom of numbness, sort of a stocking glove type of numbness, disappeared completely. And she has been seen over a month for 3 visits. Actually, it's over 6 weeks for 3 visits. And her neurologic examination of her feet is still normal. Next, we went to the upper body and to look at her right wrist. When I examined her upper extremity and right upper quarter, she had trigger points in the upper trapezius, the pectoralis minor, the infraspinatus, the biceps, the triceps, the brachioradialis, and extensor digitorum. These are common trigger points when people have forearm and upper arm symptoms. You always, as I've mentioned previously, inactivate the upper trapezius first. Once that was done, the pec minor trigger points were inactivated with the laser, and the infraspinatus was inactivated with the laser. When those 3 were done, all of these trigger points that had been seen on the initial evaluation were gone. The same type of response as we saw in the lower extremity. When I examined her wrist, I also noted that the dorsal interosseous, first dorsal interosseous muscle had an active trigger point. This was inactivated with a laser, and her normal grip strength and normal sensation over the entire hand returned. Again, this was sort of a very clear example of what can happen. Doesn't happen all the time, but it happens frequently enough that one can expect it when you're using the laser, in particular because the patient doesn't tense up when you treat the trigger point, and therefore the limb is relaxed, and they don't activate these trigger points again just from the response to the injection. So here we note that even though the EMG showed slowing conduction at the wrist, the clinical signs that she had no thumb symptoms, and the results of the trigger point treatment showed that the diagnosis was incorrect. So again, think outside the box. Simply because the patient appears to have a particular problem may not be there. Again, here is the upper trapezius trigger points that we inactivated, and here's the pectoralis minor trigger points that we inactivated. The first dorsal interosseous is right in here. When you squeeze that sort of sandwich, the patient will notice pain in the index and the small finger, and also the palm of the hand. What is an interesting side note that you can see here is if you go to the second dorsal interosseous, you may in fact be able to prevent the development of Heberden's nodes if the patient hasn't developed them at that point, if they have significant arthritis. The same is true with the abductor digiti minimi. These are both often associated with the Heberden's nodes that develop with osteoarthritis. Are there any questions about the first case? Okay, we'll proceed on from here. It's pretty straightforward, but it's a very good example of the kinds of things which you can see, which you might not expect if you're not used to treating myofascial trigger points, and in particular, if you're not used to using the low-power laser that allows a lot of these things to be seen. It's far more common than one would expect. Case number 2 is a patient, a young woman who's in her late 40s or early 50s with fibromyalgia for approximately 13 years. She presents with swollen hands with markedly decreased movement of her wrists, shoulders, and neck, and reports that she hasn't been able to really use her hands very well for the previous 13 years and has frequently had swollen hands. She has seen rheumatologists as well as her primary care doctors and has a diagnosis of fibromyalgia. She's also had diagnoses of rheumatoid arthritis and systemic lupus. Has received numerous treatments with many medications for these conditions, including several long courses of prednisone, which she is just finishing. She's clearly very depressed about her condition and is desperate to find some type of relief that allows her to begin to use her upper extremities again, since she really has very little use of them. The first thing we would do with this patient who has fibromyalgia is to begin to treat her allodynia. The allodynia is what we see as extreme sensitivity to a normal stimulus, which is normally not painful, that is now interpreted as pain. The cranial electrotherapeutic stimulation, which is microcurrent to ear clips, treats the allodynia after a variable period of time, depending. Some patients need only a few weeks of this treatment. Some people need a few months, depending on how long their fibromyalgia has been present. However, this was not available when we treated this patient, so I just looked at all of the trigger points which I could find from her neck down to her hand.